ask us your questions.
So I'll get us started. And this is like, I mean, my child is older, and so much of the problems that we're seeing are older problems. The thing that we are having the most problem with right now is bowel movements, getting them to happen consistently and to be consistent in their consistency.
In their consistency?
Yes. Any thoughts on that?
I'm going to quickly pass this to Jenny. However, this is a really common issue in all of the kids, all of the NBIA disorders, I would say, and it's a really significant contributor to just feeling badly and kind of exacerbating things. So it's a common theme throughout the disorders. One of the reasons that it's so helpful to have Jenny and other sort of disciplines working with us in the NBIA clinic in Oregon is that we have expertise to help with some things like that, and so I'm going to pass it to Jenny. Good.
That would be, and I'm a pediatric neurologist, but through my work with NBIA disorders and more broadly with kids with cerebral palsy, which is much more common, we see a ton of GI issues. I would say that's par for the course. So with constipation, there are a number of principles. One, I would say, is just stay ahead of the game rather than chasing it. So if it's been a long-standing problem, then trying to do something consistently rather than waiting until things back up for a few days. Softening the stool is important. Sometimes it's more than just a consistency problem, but a motility problem. So there are different agents that can help with motility, but you also have to approach that with caution because those can cause like discomfort essentially. And then you can, there's the option of doing things from below if needed, and sometimes that's an important approach. I would say that probably your regular doctors have their arsenal of tools to combat constipation, but don't hesitate to ask for a referral to GI if your needs are not being met. As you guys know, this is one of the issues that can really contribute to discomfort and impact quality of life. So don't disregard it and go ahead and ask for that help. Is she choking on food and water or just her own saliva and secretions?
No, we are feeding her by food, so it can be for no reason. Of course, if she has a flu or things like that, it's more common because they need to aspirate. Yeah. But without those, I think that there is one thing that contributes is the
Yeah. So Yeah, swallowing dysfunction presents, fairly early, and initially kids can eat okay by mouth, but for many kids that they lose that ability, at least to do that safely, and they sometimes lose the ability to keep up with feeding, so they end up with a G tube. And then they can have problems, as you're describing, just kind of choking on what's in their mouth, essentially, and that can lead to aspirations and pneumonias. So it's a big problem. I think there are a number of ways to approach it. It's good to have kind of specialists involved. At our hospital, we have a clinic. It's called Aerodigestive Clinic, where they have somebody who knows like the throat and the nose, and they're really good with drooling. They have a GI doctor and a lung doctor all together, because those systems all interact. And so they will see the kids individually, and each kind of talk about what the best approach is, because you can't really think about one without thinking about the other. So reflux, making sure that that's addressed if there is reflux, because that can be a contributor. The drooling can be addressed, so there are a number of treatments, from kind of minimally invasive and really minimal side effects to kind of more aggressive treatments for drooling if that's a big issue. We have a number of medications in our arsenal, botulinum toxin injections, and then the ENTs do have surgeries they can do to limit drooling. Medications, so taking a good look at what medications a child's on, and are there any there that might either increase saliva production or make it more difficult for a child to swallow, like baclofen can do that sometimes. Yeah, just I guess for the easy approach to drooling, atropine drops is like probably the safest, and they're actually eye drops that the ophthalmologists use, 1% atropine, and you can use a drop or two under the tongue just as needed, and it dries up secretions. It doesn't get very much absorbed systemically, so people tend not to have side effects. When it works great. It doesn't always work, but it's always worth a try, in my opinion, as kind of the first approach for drooling.
Our granddaughter has a couple of things along this line that ties the joking together. She's a gagger. You brush her teeth and boy, she's just gagging right away. But and the bowel movements can be a little difficult sometimes. But I wonder how much of it has to do with her diet, which is not good. She won't eat certain things, but she eats what she loves. Maybe give her a pile of French fries, and she's a good girl. But how much would diet play into any of this stuff? And what are the chances of changing her diet when she's kind of a stubborn little girl?
It might not be the battle you choose to fight. How much comfort and joy do those French fries bring? I don't know that that's a huge contributor. Of course, if your diet is narrow enough, you can run into nutritional deficiencies, but that's fairly uncommon. So I wouldn't necessarily change those things too much.
Yeah. Does she have a feeding tube? No. So she's only getting her nutrition by mouth? Yes. Yeah, so I think the key is just as long as she's getting all of the nutrients she needs, and you'd be surprised at, 4 bags of potato chips and a Coke and some Oreos can probably get you most of your nutrients. It's kind of scary. That's not strictly true. She should be eating a diet that gets her all of her nutrients. But I'm actually with Jenny on what allowing her the pleasure of eating what she wants to eat.
It can.
Yes.
Yeah, for sure. But so yeah, the P word foods are generally good. Peas, prunes, pears, peaches. But Prunes, very nice. And bananas are not good, and you want to get lots of fluids in, but if you're having trouble with diet, then we go to the medications too, so. Any doctors in the audience want to address any of these questions as well?
Yeah, so stages, like really before we had a diagnosis, like her first thing was she was not able to keep up with eating and ended up with a G-tube, and that was not fun. And then a G-tube. So that was a big problem. And then we tried many different formulas because a big problem became vomiting. Like we'd give her 2 feeds, either continuous or bolus, and it just would not move along. And so we ended up seeing Arrows Digestive. So we basically do glycerin suppository every other day. They come in these liquid little applicators, and it works very fast. Like you do it, and then 5 to 10 minutes later, you have a good bowel movement. At least for what yeah, we tried erythromycin as well, which is like an oral medication that can help move things through the stomach. I'm not sure how much that helps. The suppositories were helpful for us. And then the Motegrity works more in like the large intestines, the colon, to move things along. And the other thing I would say is, I don't know how much your kids are walking. That can be helpful, but she has a stander, and getting up in the stander is helpful too. And this like changing position can be helpful. Sometimes we'll do a suppository, and if we're not having luck, then get up in the stander, and that usually is helpful. But that has been, these issues have been a big problem with stage 2.
Thank you. Very helpful.
Regarding the research and communicating and comparative, please, what's the best way to, for example, to learn to or at least to try to include my niece or any other child from Brazil? There is a community of children in Brazil as well. We are connected, and I'm here. I'm going to pass information to them as well. So as we are far from UK or embassy, how would it be possible that we,
Yeah.
manage to have those children also considered if we need to take them there, or if we, I don't know, if when we have a kind of treatment, it can be administered in Brazil, what's the best
Yeah.
to connect it to?
Yeah, so the question is how people living outside of the U.S. and U.K. can be engaged, at least in the clinical trials that we think are coming from those sites. We are aware of the Brazil PLAN community. There's actually quite a
I have many contacts.
quite a number.
My niece that's on Facebook. We can, of course, pass to you all
Yeah,
the names of them, but
Yeah.
there are many children that
We've heard from one of their doctors too.
Yeah.
From the neurologist.
right. And actually the UK group has has worked hard to try and get connected and stay connected to the Brazilian P-LAN community through this physician. I think it's been a little bit of a challenging process just through communications, but the families can also help drive that. The UK group is very interested, and there may be an opportunity, I don't know, they would have to speak to this, but there may be an opportunity for there to be some involvement of the Brazilian families in the UK trial. I don't know enough about the US trial to really be able to make any kind of comment. So the key is establishing contact with the investigators and letting them know the opportunity. There is a lot of value in having, because it's an ultra-rare disease, in having people concentrated in one geographic area. And so that fact may, because that's true in the UK as well, the Pakistani community in England, there's an enrichment of P-LAN there. And so that's why, partly why they're able to do the trial there. But they'll be very interested. So yeah, I can give you contact information. Yeah, so putting her in touch with Audrey maybe would be the way to go. Yeah. Thank you. Yeah. Yeah, I share your, I appreciate the question, and I share, I don't know if you're raising a concern, but I share your concern if you're not raising one. I can't speak with deep knowledge about this, about why the US group chose to kind of go independently. I think it's a little bit of a reflection of maybe the INAD Cure group feeling like they didn't want to be relying on somebody else to move this forward, or maybe having the view that competition was a good thing, which maybe it is. I don't actually know. What I do know is that the UK group is well along. They've had the mouse and actually have had good proof of concept results in hand for a good amount of time, and that they're well positioned with the development of this. I'm less aware of the status of development in the U.S., and that may just because I don't know, and it's actually quite far along. But yeah, and I do think it's been a little bit of frustrating to me that there's been, I believe, some maybe ambiguity around the fundraising, where families might have thought they were fundraising for a collaborative trial, or and didn't realize that they were fundraising through INAD Cure for just the U.S. trial. And I think that was a missed opportunity to maybe provide better information.
It did seem like INAD Cure is thinking, like, they keep saying we're about to go to trial, we're about to go to trial, and then they wanted to kind of finally they go like, we're just going to do it ourselves.
The UK has never said we're about to go to trial. Actually, they've been very, I would say they've been very restrained, and I mean, I have a lot of respect for the group. They're the science and their development plan. The U.S. group is very good too, but I don't think that that's an accurate statement that they sort of gave misinformation about the timing of it. Yeah.
I don't mean that they like, I don't know, I don't think they would purposely give
Yeah.
information.
Yeah.
It's like miscommunication and
Yeah.
on the same page. So
You know, one thing.
that's why I asked.
Yeah, so one thing I have come to understand, the way that we interact as clinicians, as physician scientists in the US, the way that we interact with the family community and with fundraising, with philanthropy, as a general statement, is actually very different than the way they do it in the UK. And there's a very bright line, there's a wall, much more, I don't know if it's cultural, I don't know if it's an academic thing, I don't actually have insight into it, but in the UK, the physician scientists, I mean, they'll interact with families in a family advocacy meeting, but they are not the people out kind of working to fundraise for a therapeutic that they're trying to develop. It's an ethical bound that doesn't align with the way they work. And so that may have been misinterpreted, I would say, by the U.S. group as the clinicians didn't want to work with them or something like that. But it's actually a cultural thing or a societal practice that's very different than it is here in the U.S.
And I do know that on Saturday, Audrey Sue from the UK will be speaking, I think live and not recorded, but live on Zoom with the group, and then Guan from Hugo's group will be here. I'm pretty sure, yeah. So at least the other US group will be here, so there might be more opportunity for questions about kind of what's going on. And
So Audrey Sue in the UK works with Manju Kurian, so that's the UK PLAN trial. And they've done some really, really good work in natural history and retrospective natural history. So collecting the past information. I know that many of your families are involved in the PLAN Ready, which Allison runs, which is the prospective, looking forward, what's happening now and what's coming, natural history study that we're running. Those results will serve both of those trials. The PLAN Ready results will, but Audrey will be talking, and then Guang Lin is a scientist who works with Dr. Bellin at Baylor, who it sounds like he'll be here also speaking. So maybe they can talk to you a little bit about the trial or trial plans.
There are no studies in the United States that are open right now, though, from what participating.
There are no interventional trials that are enrolling. So Allison's leading the natural history study, which is a clinical trial. It's just not giving people something to look at if it's changing the disease. It's rather an observational trial. It's gathering natural history so that we can be ready when a trial is ready to start. You can actually go to the clinicaltrials.gov website, all one word, clinicaltrials.gov, and type in PLAN or INAD, and you'll see the trials that are open at any time and whether they're recruiting, what the status is. I think the Decipramine trial is in there. The RT001 trial is in there, although I think it's incomplete information. I'll talk a little bit about that on Saturday. Yeah.
You referred to INAD. We're dealing with ANAD.
Yeah, ANAD is atypical NAD or neuroaxonal dystrophy. It's the ANAD and juvenile PLAN are kind of the same thing. INAD and infantile PLAN are the same thing. Yeah, we're still interested in kids with juvenile PLAN and adults with PLAN. We're interested in the whole spectrum.
So if I went to these clinical trials, though, I couldn't find anything for ANAD. If I looked it up.
Well,
you'd find our study. You'd find our study. Ours, I think, is probably listed under PLAN, but it has other keywords where you can search for INAD or ANAD or PLAN. But we have, I'm going to give an update on Saturday, but we have many atypical NAD or juvenile individuals in that study.
It's an important question you're asking. I don't actually know the answer. I don't know the answer. So one way that I could imagine it being available is if a trial is opened. So by definition, the FDA has signed off on a trial opening. That is, the preclinical safety data are enough that they are comfortable with it going into humans, and a child or adult doesn't qualify based on the enrollment criteria, I could see in those kinds of cases that might be a way to have the sort of compassionate use or single use, single IND kind of approach possible. But yeah, the FDA usually wants to push people into trials. They're not, yeah.
Just thinking about the UVA5 situation with, but I don't know where they're developing an N of 1 treatment.
Yeah, so Jenny's talking about, what are called N of 1 treatments, with the understanding that many of the kids with INAD, ANAD, have their own mutations, their own sort of flavor of the disease, and whether there's a kind of a path to a trial that involves only a single person, and that may be, there may be a path there. I think for gene therapy, it's going to require still a little bit more development work. And again, I don't think the challenge is I think what the challenge is and will be is reaching the whole brain. Yeah.
The British group or the group in the UK has not published their mouse trial. The only publication I've seen is someone's graduate dissertation,
Yeah.
which was promising.
Yeah.
And they looked at different ways of delivering things like, injecting it into muscles, injecting it into the peritoneum. And I think, from my perspective, probably like a lumbar puncture intrathecal injection would probably be the best way to reach the CNS and the peripheral nervous system. I think that would be the best option.
Yeah. Yeah.
And that's that. So you look at like SMA is another genetic disease, kind of similar. It affects the peripheral nervous system only, but the way that they have approached their genetic treatment for it is by doing intrathecal.
Mm-hmm.
And so, like in the cerebrospinal fluid, so a lumbar puncture, do a lumbar puncture in the low back, and then inject there. I think that's my personal opinion of the best way
Yeah.
to reach all of those cells.
Yeah.
But so I think it's sort of my frustration with the UK group that they're moving forward with these trials, but like I'm not for peer review published any of their data.
Yeah, that's a fair criticism. So I sat on the thesis committee for that student, so I can tell you that there's more data than what are in the thesis, and I can tell you that it's really promising. So and it was done, a while ago. I don't know the full range of reasons for why they have been slow. It's not for it being that they can't get it published. And I can tell you the quality of the work is to the highest standards. I think it may have been, partnering with pharma to try and develop this, and part of what they think is their their advantage, if you will, is actually their modes of administration, that they have good data, that this and this is the best way to reach the full central nervous system. And so I both hear what you're saying, and I get your frustration. I've kind of seen their data, and I'm very, very positive. I'm very encouraged.
It sounds like the other thing that they have working to their advantage is they have like some larger animal models that, instead of just mice,
Yeah,
like another
sheep.
sheep model.
They have a weird Pelan sheep in the UK. Naturally occurring sheep with, and they've tried to establish the colony, but unfortunately it's very expensive. You think mice are expensive, try keeping a flock of Pelan sheep. It's a very expensive endeavor, but it is really helpful to have large animal models for this disease and others, to do those safety studies and to do those, how do you get enough gene delivery into a whole brain of a large brain. Yeah.
You guys talk about some
Sorry, I didn't hear what you said.
There's a medication called semaglutide. It's a diabetes medication, and there was a publication recently that was in a plant, pelan animal model that showed that it was helpful in sort of delaying onset of symptoms. Some interesting data there. It is already on the market. It's an adult drug, and dosing it, the way they dosed it is there's very high doses of it. But
That one got by me. I'll have to go and look. Yeah, yeah.
I haven't seen it either, so I'll take a look, and I've been reviewing all the PLAN studies periodically, so.
Really have been.
You sound like you are a great resource for this community, and highly driven. I know I'm not putting adequate emphasis on that. I'm curious, well, it would be great if there was a way to harness your drive and your expertise in some way. I'm just putting that out there. I don't know.
I'm feeling it's a lot with
Yeah. Yeah.
I mean, you're putting it in
Yeah.
yeah.
way back.
Yeah. It sounds like talking to Audrey might be
I think so.
a good idea.
I want to do that. I have a lot of questions.
So this is a question that's come up regularly on the Facebook group with especially younger kids having what seems like night terrors or something like that. They wake up screaming or they have very difficult time falling asleep, and there's a lot of screaming involved. We passed through that as a phase. Fortunately for us, it didn't last forever. But is that something that you've run into, and do you have any recommendations?
So I'm not on the Facebook group as much as some people. But I know families that have contacted me asking a similar question, but what they've described doesn't sound like night terrors to me. It almost sounds like, you and I have talked about this, if either a developmental phase they're going through or some kind of other discomfort where some people have decided later it was reflux or the start of spasticity. You know, they've started baclofen and maybe it got better, that kind of thing. So if you think it's truly night terrors, that's different than what I've heard of from some other families, but I have heard about like difficulty sleeping, discomfort with sleep, waking frequently, that kind of thing.
That's a much better description. Yeah.
Okay. You and I have talked about that a little bit.
Yeah, I mean, I think like conceptualizing PLAN is involving dysautonomia or dysregulation of the autonomic nervous system, which is involved with pooping and peeing, and is also plays a role in sleep and maybe part of why there's sleep disruption. But sleep disruption is, something we see in a number of developmental disorders, and it's one of the hardest things to understand and to address. But usually, like, you know, I kind of go through a series of thought processes and about like certain things that might contribute to kind of overnight wakening and disrupted sleep, and kind of check boxes in terms of, is there iron deficiency anemia that might be causing restlessness, waking kids up at night? Is there sleep apnea, any signs or symptoms, and do we need a sleep study? Is that contributing to the wakening and then the screaming? Behavioral, sometimes the behavioral sleep disorder presents that way. So is the child falling asleep with, a comfort item, and that item's not there when they wake up and they're screaming? Or is it pain? And try Tylenol before bed. Does that change anything? So it's kind of like this scientific investigation of what might be contributing to sleep issues. Sometimes we check all those boxes and I can't find anything. And also think about, well, can we treat this in a way that doesn't cause harm but is helpful? And usually that involves just kind of benign measures like white noise machine and weighted blanket, or things that are totally benign and might help. And then moving on to melatonin, which I consider benign. I know there's a lot out there on the internet. And then we can try other things for sleep if needed, but sleep's a big mystery.
do feel like, and I don't know if you've gotten this impression, Matt, that eventually they work through it, even if they don't identify exactly what the problem was. Like, it doesn't last forever. It might feel like it. I know. But it, at least the families I've talked to, it didn't.
No, not at all. She, I don't know if she sleeps like at night. She sleeps a lot during the day, but she, just kind of picks it whenever she wants to fall asleep. She falls asleep, and yeah, she's delightful. She wakes up happy. Seems to get better sleep than I do.
How old is she now?
She's 18.
And when did you not have to worry about the non-sleeping through the
I want to say that there was a year there where it was really bad, from about 2 to 3, but it could have been longer than that, or it could have been shorter. Could have been much shorter. It felt like
The next stage has like that, not consistent, but actual. So this is kind of stereotype thing where she wakes up and she looks like this. It goes away pretty quickly, but it happens sometimes from time to time.
Now we have a backup now, gabapentin, if she wakes up with that neuroagitation.
So for spasticity, we've been using baclofen. It's been helpful, but I don't know what your experience with botulinum toxins, muscular botulinum toxin. Like, have you used that at all for PLAN?
So I've only had one patient, and when I took him on, he was in the later stages of his disease and wasn't needing it. He was just on baclofen at that point. I have a lot of experience with botulinum toxin in a lot of conditions, though. And generally, I would say that if there's a really valuable goal to shoot for with it, that it may be reasonable, but the upside and the downside is that it's temporary. So if you don't like the effect, great. But if you like the effect, you got to keep doing it generally to maintain the benefit. But sometimes the goals are like, well, we just want to, have our child continue to be able to stand so that we can keep bone density, prevent fractures, help with the GI system. And the issue is range of motion at the ankles, and so that might be a meaningful goal. And they're not tolerating braces and casting, so that might be a reason to consider it. Or discomfort because of adductor tightness or hip dislocation might be a great reason to consider it. So I think it's on the table, but you got to be thoughtful about it. Yeah, I mean, just kind of we skirted around bone health a little bit, but I think what we've learned from kids with cerebral palsy and a lot of other disorders that involve loss of ability to be standing and weight bearing is that the bones suffer from that. And weight bearing is what builds bone density. Kids are at risk if they're not weight bearing then, but they're also at risk for nutritional reasons. So just from having the disorder that they have, they may not be getting quite the same nutrition. So those things may not present early on, and so it's a kind of this invisible threat. And then as kids get older, that's when their bones become more and more fragile. And sometimes just a diaper change may be enough to cause a fracture in an older child who's had long-standing PLAN. Now, this is not true for everybody, so I'm not trying to scare everybody. It doesn't happen that often, but it is a risk. And the things that you can do are weight-bearing activities. So even if your child doesn't walk, using a stander to just get that weight bearing, and then vitamin D supplementation, which I think is a good idea for everybody.
Another issue with my niece is that her head and my sister's kind of robot. Does it help to
say a robotic glove?
Robotic, yes, robotic glove.
Yeah,
You put here and turn on and the glove
Oh.
is kind of.
gotcha. I mean, I think you can go lower tech than that, and just start with like a old-fashioned splint, but one that's made for her. Like basically you can mold a splint specifically for the child's hand, and it holds the hand open. And basically over time, people develop contractures because they're not getting enough range of motion. So if you're always like this, over time you'll get more and more stuck. So to prevent that, you need to get that range of motion throughout the day. A splint just holds the hand open, so as long as you're doing it for enough time during the day, maybe that's a few hours, you're gonna get that, maintain that flexibility. I don't think it necessarily needs to be robotic, and I don't think there's data or that technology is not at a place where we know that it helps anything, so, yeah.
Thoughts on scoliosis?
Yeah, that's a broad statement, a broad question.
How do we manage
Yeah.
that? How do we limit it if possible?
Boy, yeah, so scoliosis is a contracture of the spine. In the same way, the hand, if it doesn't get enough flexibility or range of motion, you get stuck. That happens to the spine too. So, you know, either tension or just weakness and being in one position, not getting enough movement, over time you get that contracture and that scoliosis. So initially kids may sit a little crooked and you can still straighten them out, but as they get older, they'll get a little bit more stuck and you can't straighten them out anymore. Sometimes it's not a big problem. In some of our kids with INAD, it can be a big issue as they get older. It may not be, so prevention, in kids with low muscle tone, there may be a role for a trunk brace. In kids with high muscle tone, like cerebral palsy, we don't actually have a good way to prevent it, but in kids who are lower muscle tone, there might be a role for having a trunk brace. So just to kind of help with posture a little bit, I'm not necessarily saying every kid may need that, but it might be something that can be used and tried. Mhm.
Well, I just want kind of to play out that a little bit. Like, my conception of this is both high muscle tone and low muscle tone. Like, have you seen different, like, are some people more on the hypotonic end and some people are more on the spastic end? Like, because this seems like a problem of both low muscle tone and
Yeah.
spasticity.
I mean, I think well, with INAD, early on, you're going to see low muscle tone, and over time, you see more high muscle tone. But I think later on, sometimes the higher muscle tone tones down a little bit. So I think you're right. In that case, it's not 100% clear if a splint or a brace is necessarily going to prevent anything. So do you have more to say there?
Well, I know that particularly in the juvenile PLAN, the atypical NAD and the later onset, sometimes what enables the kids to continue to stand or walk or be at least independent to some extent is to actually preserve some of that spasticity, that it helps to balance out or overcome the muscle, the weakness. I think that's less true in the infantile form, but yeah.
And with scoliosis management, that is going to be very child dependent. So if a curve is starting to progress more rapidly and it's not yet causing problems like difficulty with breathing and comfort, it's going to depend on the child and whether it's worthwhile to do such a big surgery or not. So a child with INAD, maybe it's not worth it if their health is not as good, and maybe it's not worth it to put them through a big surgery like that. It may not change things dramatically and puts them at a lot of risk, but it's you just have to have a very careful discussion with surgeons and other doctors, because it may not be the right move to do that.
Along the lines of surgery, I've heard people complain that that going under anesthesia is a problem for their kids. We haven't seen that. We don't seek it out. We don't try to put her under. But on the few occasions, I personally haven't seen an issue. Is that something that's just anecdotal, or is it something that you've seen borne out?
From a sort of from a kind of biochemical standpoint, I don't think so. So yeah, I mean, pecan's different, but I don't think that there's something intrinsic to the biology of pelan that makes anesthesia risky. It more about kind of their baseline neurologic status, and maybe interactions between the medications, the anesthetic medications, and either their disease or the other meds that they're on. But I don't know, do you have further?
I mean, there had been some hint of this from the group in the UK too, and we've talked to Manju's group about this because families there have asked them. So we agreed to start asking in the natural history study. So it is something that we're trying to track now, and we ask about both general anesthesia and sedation, like for an MRI. I mean, just me looking at the data as it comes back in, I've seen plenty of people say, no, we had no problem with that. So I don't know what it's going to tell us long term, but we're tracking it.
Never missing an opportunity to plug the PLAN Ready study. You probably are all in it, but when trials, interventional trials do come, everybody who wants to do a trial is going to require some baseline natural history data, and so this is what you all can be doing right now to be preparing the community for trials. So thank you to those of you who are participating. It's really, really important.
I'm sure everybody in the room is, but there might be a couple of people on Facebook who
Good.
aren't aware of it.
Hear that, Facebook?
Participating with us, yeah.
What about visual symptoms? I mean, so probably the earliest onset thing for stage that we noticed was she developed mesotropia. But I've heard that a lot of IDAD and AGAP, ELAN children develop visual issues. Like, is there anything to be done about that, or just kind of try and follow it?
Atrophy.
Yeah, I think that's one of the, or sometimes earliest and most obvious presenting symptom for some kids is you'll see some nystagmus or esotropia and optic nerve atrophy and a variety of other findings. I think we're learning. And hearing issues, there have been some recent studies demonstrating that hearing loss is pretty common as well, so just something to screen for. We don't have anything specific beyond supportive care for it, so just what your ophthalmologist recommends, and there may be a role for glasses in some children, but we don't have any specific treatment or approach.
Yeah. Yeah, there actually is a Parkinson's for kids, a true Parkinson's for kids, and that you give them Parkinson's medications and the whole world changes. This is not that, so you're right. I think of this as much more just kind of broadly psychomotor regression. It's everything with the cognitive function and every neurologic aspect of the neurologic system struggling to function. And so I think of it more as a weakness and kind of broader deterioration. Yeah, so I don't, even though the adult forum does have Parkinsonism as part of it, this is not a Parkinson's disease for kids, yeah. Even, I'd have a little trouble even with the ALS, but I understand it's helpful to kind of be able to refer to a common neurodegenerative disease. It's probably as good as you're going to get.
I say it's the whole nervous system.
Yeah, exactly, yeah,
I don't know if there's a better way to describe it
yeah,
than dementia.
yeah. It's actually a good way. What you've come up with, I think, is probably the best way. Yeah.
What I'd be interested in knowing, there's maybe no way to really know it, is as things progress and kids like ours with ANAC start to regress, how much do they know of what's happening to them? Or once they've reached a point where they're non-communicative and certainly non-mobile, how much do they still retain of their knowledge that they gained of the world around them beforehand? I'm thinking down the road of what happens to a person who's experienced things, who is going to lose the ability to experience those things.
That's an unanswerable question, but an excellent question. I'm just thinking of one kind of different situation, but maybe might be helpful, is we sometimes see kids have really bad kind of strokes where they don't get enough oxygen to their brain, and we look at like their MRI picture and we're like, oh my gosh, and we give this devastating news to the family, and things are not going to be the same. But then if you you fast forward 3 years and you see the child, they have their same personality, and okay, things are not exactly the same, but that child is still there, and yet looking at their MRI, you would think that that child would be half the child they were before, but still that personality is there, and they're not a different child. So just a thought that maybe that person remains that person to some extent, but this is conjecture, and I think we don't know the answer.
As a parent with a child who's further along, they do keep their personality. At least ours has. Yeah, she still has a sense of humor.
Yeah. Can she speak?
Yes, she says the same things kind of repetitively. She's got her things that she likes to talk about. So she's got Sandra Pointy book memorized, blah, 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 blah. And we'll go into change a diaper at 2 in the morning, and she'll be quoting it verbatim, or like a segment of it over and over again.
Ours doesn't like to read or be read to.
There are things that can happen.
She's a jokester. She does have a really fun personality. But she'll say, I don't like learning.
So we're around for the next couple of days, some of us through to the bitter end. So you should feel free to come up and ask us questions and spend some time together. I'm interested in talking to your family and connecting you to the UK group so you can get a sort of direct feel for them. Is Audrey actually, is it a recorded talk or is it a live talk on?
Let me check. It's
Yeah.
listed in here. I think it's live.
Okay. Audrey is the fellow in the Korean Rahim group who's working on the gene therapy project and actually the natural history, and she's sort of become the kind of PLAN champion, all things champion in that group. Yeah. Pre-recorded. Okay, so that's okay. I'll take the opportunity, and I might catch up with you independently and figure out a way to make that connection. Okay. Yeah, again, I think that's yeah. It's nothing personal. Nothing personal.